Hello, this is Dr. Erik Pedersen. We're going to go through a CT angiogram. Um, this is case 9221. The companion case is the non-contrast head CT, case 9220. So please watch the 9220 video first, and then this one, 9221. So this is a CT angiogram on a patient who's presenting with acute left-sided stroke symptoms. And so our standard protocol for CTAs is going to be these thin source images that are generally on the order of anywhere from zero 0.6 to 0.75 millimeters thick. So they're very thin volumetric axial reconstructions. And those are the ones that we have here. And then we have some other axial sections. We have a thicker set of maximum intensity projection um, slices that basically show us a thicker slab of the vessels, and it lays the vessels out kind of nicely. We'll take a look at those. And then we have thin coronal and sagittal maximum intensity projection reconstructions of the vasculature. Obviously, this is a study that's performed with IV contrast, and the bolus, the scanning is timed to the bolus injection so that we get mostly arterial opacification. You can see there is some venous opacification here, particularly in the superior sagittal sinus and some of the other dural venous sinuses. But we get nice arterial opacification. So the way I look at these is I use the source images for kind of my heavy lifting sequence. And basically, it's just a game of follow the plumbing. Normally I start with the right internal carotid artery. We're not going to do that on this patient because it's abnormal. So we're going to start on the left. And my approach to these is the first thing I do is I start with the carotids. And here's my pointer that's on the distal cervical segment to the left internal carotid artery. And as we scroll up here, we can see that that left internal carotid artery is going to enter the skull base, and it's got goes into the skull base here along the horizontal petrous segment, and then it's going to work its way up to the cavernous segment, which is the next kind of horizontal portion here. And you can see that there's a little bit of atherosclerotic calcification along this distal left internal carotid artery. And there isn't really any evidence of a significant focal stenosis that goes along with this. Now, the one thing that I want to point out to you guys is that right here, there's a little branch vessel that comes off of this left internal carotid artery. That's actually the left ophthalmic artery. And the left ophthalmic artery isn't terribly important for us, other than it's a place where you can get aneurysms rather uncommonly. But anatomically, it marks the location where the carotid artery basically extends through the dural ring and goes from extradural to intradural. That's important for assessments of aneurysms and things like that that are really beyond the scope of what we're talking about today. But anyway, ophthalmic artery origin, then we kind of get to the clinoid and supraclinoid segments of the internal carotid artery. And as we follow it up here, and then to the carotid terminus here. You can see the carotid terminus a little bit nicer on the coronal reconstructions. Here it is on the left. Here's the terminal segment as it goes vertical, and then that divides into the left middle cerebral artery and the left anterior cerebral artery. Now, one of the things that we want to look at very closely is one of the places where aneurysms like to form is along the underside of the supraclinoid segment of the internal carotid arteries. And you can actually see we've got this little bump that extends off the bottom of that segment here and goes down and stops. And you can see that on these reconstructions here. There's a little bump that's off the bottom of the supraclinoid segment of the ICA. That's actually a tiny aneurysm. It's a little branch that basically goes down into nothing. right here at the tip of the arrow. So this patient has a 2 millimeter, this is a PCOM origin aneurysm arising from the supraclinoid segment of the left internal carotid artery. Anyway, the left internal carotid artery is patent. We've noted the aneurysm. And so now we're going to go and look at the distal right internal carotid artery. And hopefully right away, you realize that when you go and look for the distal cervical segment of the right ICA, it's not there at all. There's no contrast enhancement in it whatsoever. There's no counterpart to this enhancing vessel here. And as we come up further, you can also see that in the petrous segment, there's no enhancement within this distal left internal carotid artery. We come up, we get to the cavernous segment, again, no enhancement whatsoever within the vessel. It should be right here. And then we come up to the clinoid segment and the supraclinoid segment, again, no enhancement whatsoever on this left side. And even as we come up to the terminal segment, which should be right here, there's no enhancement in that terminal segment. So the distal right internal carotid artery is more likely than not occluded throughout its visualized portion here. You'll also see that the next thing we're going to assess is the anterior cerebral arteries. So here are the anterior cerebral arteries on the left and then on the right. And then we get the anterior communicating artery, which we can see is very small. So the ACOM is actually very hypoplastic. Either that or it's absent. So we can't really see it, but you can see the A1 branch on this side. This A1 branch on the right side is probably filling, presumably retrograde across a hypoplastic ACOM because there's no supply from this right carotid side. So we follow the anterior communicating or the anterior cerebral arteries up and around the corpus callosum, and they come along the medial portion of the frontal lobes here in the anterior intrahemispheric fissures, and they actually look okay. So now we're going to do the middle cerebral arteries. The middle cerebral artery on the left is here. It's this branch that kind of follows through here. You can see it laid out more nicely on the MIP. You can see here's the MCA bifurcation or trifurcation, and then see the branches that go out into the Sylvian fissure here. So basically the left middle cerebral artery is laid out quite nicely here and looks widely patent. And we can follow all the spaghetti out by scrolling through and following each individual branch on the source images. And we'll do that as part of our assessment. So the left MCA is cleared. Now, the right MCA, again, we've got a problem. Remember, we had that hyperdense segment that was right along here on the non-contrast CT. There's no contrast enhancement whatsoever within this M1 segment of the right middle cerebral artery. And you'll also notice that here on the MIP images demonstrates it quite nicely. There is some filling of these Sylvian branches of the middle cerebral artery out here, even though there's no contrast enhancement within the more proximal segment. This is probably being filled via collaterals from small leptomeningeal vessels, because we really don't have any collateralization that we can see here. It's just occluded. So this is probably some leptomeningeal collateral filling of these Sylvian branches of the middle cerebral artery on the right. Again, you can see that the enhancement, even within those collaterally filled MCA branches, is much less, right? It's asymmetrically less enhancing on this side than it is on this side. Okay, so we've talked about the middle cerebral arteries. The next thing we're going to look at is the posterior cerebral arteries and the posterior communicating arteries. We don't see posterior communicating arteries on either side here. They're either markedly hypoplastic or absent. The bilateral posterior cerebral arteries are arising from the basilar tip. You can see that nicely here on the coronal. Here's the basilar artery. Here's right posterior cerebral artery, left posterior cerebral artery. Here's that on the axial images. Here's the basilar tip. Here's right posterior cerebral artery as it comes around in the perimesencephalic cistern and comes all the way back, and it sends branches back into the occipital lobes. And the same thing on this left side. the P1 branch, and then back around in the perimesencephalic cisterns, and then back to the occipital lobe. So those look okay. We can also follow them on the coronal images here. Those all look fine. So now we're going to run down the vertebro-basilar system. So here's the basilar artery at the tip of the arrow. It's going to come down here, and you can see it's being fed by the left and right vertebral arteries, and they look fine too. So the impression here is occlusion of the entire visualized portions of the right internal carotid artery from the distal cervical segment all the way through the terminus, with apparent occlusion of the proximal portions of the right middle cerebral artery.